A bone marrow aspiration typically begins at the posterior superior iliac spine of the adult pelvis. Before a pathologist evaluates individual cells, the first objective of a myelogram is to assess the large-scale structural integrity of the marrow space. Inside the spongy trabecular bone, a constant spatial competition plays out. Active, blood-forming tissue vies for volume against dormant adipose tissue. This femur diagram illustrates the divide. The red bone marrow is the active site, where stem cells produce blood cells. Panning down, we find the yellow bone marrow. Composed of lipid cells, it serves as an inactive fat reserve. Before specific disease states can be identified, the diagnostician must first quantify the geometric balance between this active red tissue and inactive yellow fat. Normal bone marrow cellularity is governed by a strict mathematical rule tied directly to a patient's age. The formula is 100 minus the patient's age plus or minus 10%. A 20-year-old expects roughly 80% active cellular density, while a 60-year-old expects closer to 40%. When a sample's active density falls significantly below this age-adjusted baseline, it is classified as hypocellular. A hypocellular finding suggests the marrow's production factory has been shut down, a state found in aplastic anemia or following exposure to chemotherapy and toxins. Conversely, a hypercellular marrow exceeds the age-adjusted baseline. This overpopulation points to unchecked proliferation, often driven by leukemias or other myeloproliferative disorders. Age is the mandatory mathematical baseline. Without knowing the patient's age, a quantitative diagnosis of cellularity cannot be performed. Once proper cellularity is confirmed, the analysis zooms in. The objective shifts from measuring total volume to tracking the sequential maturation of individual cell lineages. The first major lineage is the Erythroid series, whose primary function is producing red blood cells. This graphic isolates the erythroid maturation gradient, progressing from the proerythroblast through basophilic, polychromatic, and orthochromatic stages to a reticulocyte. Below, the Myeloid series produces granulocytes, maturing through myeloblast, promyelocyte, myelocyte, metamyelocyte, band, and mature neutrophil. Normal maturation requires a continuous spectrum of all these developmental stages. Finding only the earliest blasts or only the latest mature cells indicates a maturation arrest. Cellular differentiation is a visible, measurable timeline. Within this framework, missing or arrested maturation stages provide the anatomical evidence of underlying hematopoietic failure. These two primary lineages do not exist in equal numbers. Their balance is strictly governed by the myeloid-to-erythroid, or ME, ratio. The normal ME ratio is 2:1 up to 4:1. Granulocytes outnumber erythroids because short-lived white blood cells require constant replacement. A decreased ratio under 2:1 indicates a red blood cell surge, compensating for deficits like hemolytic anemia. Beyond these two primary lines, the marrow contains minor yet critical cellular populations. Massive megakaryocytes reside here, fracturing their cytoplasm to generate platelets. Then there are the plasma cells. These are the antibody producers of the marrow, and as the notation emphasizes, they normally constitute less than 5% of the total cellular population. Plasma cells must be strictly regulated below this 5% threshold to maintain immunological balance and prevent the overproduction of singular antibody clones. The normal marrow is a tightly regulated mathematical environment where strict volume ratios between lineages govern the body's immune and oxygen-carrying readiness. True pathology is diagnosed when these established numerical thresholds for cellularity, ME ratios, and minor cell caps are broken. The criteria for acute leukemia are explicit. Blast cells exceed 20%, suppressing normal marrow. Multiple myeloma is driven by plasma cells pushing past 10%, displaying abnormal binucleated morphology. Chronic leukemia differs visually. It presents as an overcrowded hypercellular marrow, driven by an excess of mature granulocytes. Aplastic anemia represents the opposite extreme, a hypocellular marrow replaced entirely by fat vacuoles. Malignancy is identified by mathematically quantifiable violations of normal lineage thresholds. Counting cells and evaluating morphology is sometimes insufficient to differentiate complex overlapping anemias. To resolve this, pathologists use Perls' Prussian blue stain to visualize the body's iron metabolism directly within the marrow space. An iron stain reveals the truth. A pale background with absent iron stores confirms iron deficiency anemia. If iron metabolism is defective, iron accumulates pathologically within the mitochondria, forming distinct dark blue rings around the cellular nuclei. The presence of these ring sideroblasts serves as the definitive marker for sideroblastic anemia. Alternatively, a finding of increased iron deposits without ring formation suggests hemochromatosis, or the consequences of repeated blood transfusions. A complete diagnostic evaluation requires synthesizing the spatial geometry of cellular maturation with the biochemical reality of metabolic storage patterns.